everybody. On behalf of the Times-Argus and Orca Media, I'd like to thank you for coming out tonight to hear about this really important issue. My name is Steve Pappas. I'm the editor of the Times-Argus, and I will be moderating tonight's panels. I use the term plural. We were very fortunate in asking all of these folks if they would be willing to come talk. I thought if I invited a dozen people, I'd get 6. I got 13. We're all here to get information from the very people who are dealing with the opioid crisis on the front lines, and we're all here to have a better understanding of what's happening in our communities. And we're eager to know what's being done to tackle this crisis at all levels. The next 2 hours are probably going to be pretty sobering. I've been assured by some of the folks that that may not be the case, that they have some good news to report as well. Hopefully it won't be too upsetting. What these presenters are going to convey to us will be the opioid epidemic through their very specific lens. That's what I've invited them to do tonight. As a group, they are going to connect certain dots for us, and they're going to give us, hopefully, the most comprehensive look at how one of the most influential factors that in our culture is tearing apart much of the fabric of our communities. So, at its barest minimum, this forum should be a reminder that we really are all in this together. So let me take a moment to talk about the format tonight. The first panel will be mostly talking about scope of the crisis of the opioid epidemic. We've had to mix and match a little bit to accommodate some schedules. Each panelist will give a brief presentation, and we will open things up afterward to questions from the audience. So after about an hour and 15 minutes, we will seat the second panel, which will mostly focus on law enforcement, criminal justice, and addiction treatment. There also will be time at the close of that particular panel for questions from the audience as well. If you do have a question, and I would ask that you wait until all the presenters have made their presentations, come up to this microphone, because we need for everyone in the room to hear you, as well as everyone who is watching this live streaming, and we're also taping it for rebroadcast on public access television. Thank you, Orca Media, for doing that. So I would ask you to please keep your questions about the topic at hand, and understand that due to privacy issues and ongoing investigations, our panelists probably are not going to discuss any specific cases with us tonight. And let me briefly introduce our panelists. They're on your program, but if you would stand, if you're seated, or wave from the stage when I announce you. Tim Bombadier is the Public Safety Director for the Barre City Police Department. Brandon Del Pozo is the Police Chief for the City of Burlington. Ann Gilbert is Director of Central Vermont New Directions Coalition. Deborah Hopkins is Director of Central Vermont Substance Abuse Services. Dr. Mark Levine is the Commissioner of the State Department of Health. Neil Martell is a Captain for the Montpelier Police Department. Dr. Javad Mashkouri is Medical Director of CVMC's Emergency Department. John Merrigan is Commander of Special Investigations for Vermont State Police, which includes the Narcotics Unit. Mary Moulton is Director of Washington County Mental Health Services. Dr. Josh Plavin is Vice President and Chief Medical Officer at Blue Cross Blue Shield of Vermont. Robert Purvis is Director of Turning Point Recovery Center in Barre. Evan Smith is Lead Clinical Care Associate for CVMC's Medication Assisted Treatment Team. And Rory Tebow is our state's attorney. Thank you all for coming. Let's get started. Thank you. Thank you. I'm going to ask Dr. Mark Levine to start because he is the one who can probably give us the scope of the opioid crisis in the state of Vermont. Dr. Levine, just lean right into your microphone if you wouldn't mind.
Good evening. I'm the one who planted myself here to give you both good news and bad news. But it's always better to start with the good news. But I'll quickly answer the question about scope because it's a very challenging question to answer. Currently in the state of Vermont, we have over 8,000 people receiving medication-assisted treatment. If you do the math with the population of Vermont and subtract everybody who's under 18, it comes out to about 1.6% of our state is receiving treatment for opioid use disorder. Estimates from across the country indicate that most people who have this disorder are not in treatment. So it becomes even more challenging to figure out how many people in Vermont actually have the problem, because we only see perhaps the tip of the iceberg. But the estimates are anywhere in the 20 to 30,000 range. So quite a bit more than those who are actually involved in treatment now. I have to tell you in the good news department that we've really made great progress, and we are a state leader when it comes to the battle against the opioid epidemic. Governor Scott and a few of us in the Agency of Human Services were invited to testify before the House Ways and Means Committee last week, based on the fact that the model of care that Vermont uses is widely respected, and that they thought they had something to learn from us. We had a few asks of them as well with regards to how things in Washington are paid for and how they could further encourage the country to cope with this crisis in more productive ways. But they genuinely wanted to hear from Little Vermont. So we're especially noted for our efforts in treatment. And as you know, treatment in this arena is called medication-assisted treatment. So that's usually the use of methadone or buprenorphine as a medication to quell the cravings that people who have this substance use disorder get so that they can function in their day-to-day life. Medication-assisted treatment comes as a package, though not everyone wants to access the whole package. It may involve counseling, it may involve lots of social supports, case management, things of that sort. It's meant to be a comprehensive approach. And it's really built on what we term a health home model or patient-centered home model that treats opioid use as a chronic disease condition, just like diabetes, heart disease, whatever. And that's a very effective model because for many individuals, it can actually pave the way back to living a pretty normal life, except for the fact that they're taking a medication every day, just like somebody with one of those other diseases may be taking a medication every day. If you talk to myself and perhaps some of the other panelists and people who are actively involved in treatment programs, they will tell you that it can be quite gratifying because there are lots of people who are doing well in those programs and having a functioning life. We recently had a study commissioned of the hub and spoke treatment program, and it pretty much validated why we're doing it and how effective it can be. And there were startling decreases in the ongoing use of either oral or injectable opioid medications by those who were getting medication-assisted treatment. And compared to with the group that wasn't getting the treatment, there was 0 overdose deaths, 0 overdoses actually, in the people who had been sticking with their medication program. The good news now is we have not only evidence-based expertise at medication-assisted treatment, but we have capacity. And pretty much through the state is almost a 0 waiting list to get in. Used to be in the news all the time that there were waiting lists, hundreds of people, and that's no longer true. So the hope is, with that kind of capacity, that individuals who may not have chosen to seek treatment up until this point will recognize that if they're motivated to do so, they can immediately get into that. The hub and spoke system, just to give you a sense of what it involves, there's an intake process, and someone with opioid use disorder who wants to be treated pretty much fills out a questionnaire, and you gain an understanding of their medical history, their psychiatric history, their substance use, their support systems, family, income, employment, housing, whole host of factors. If it's deemed appropriate for residential treatment in a facility for several weeks, there's access to that, and that's probably the minority in this state. If it's deemed that they can use methadone as a long-term treatment, they go to what's called a hub, of which there are 7 around the state, and those hubs are where you would go every day to get medication and all the other comprehensive services. And they're more high-intensity settings, but they're staffed by addiction specialists and are a great resource. If, on the other hand, things are a little more together in your life, you may actually go to a spoke, which is a primary care practice, sometimes a mental health or OB practice, and receive buprenorphine. And you may actually only have to go there monthly and have a monthly prescription for a pill that you'll take every day. That system seems to work very well, and as I alluded to, can integrate people back into a functioning life, something they might not have had when they were using heroin or prescription pills. The other good news I have is that there's active strategies in harm reduction. Everyone in the room should know that if they want access to Narcan, naloxone, it's there for them for free or with a copay at a pharmacy. And you don't even need a prescription. There's a standing order for it. There are syringe and needle exchanges in the state that keep people a little safer if they're going to continue to use the injection route. And there's safe disposal and sharps disposal, and we're trying to increase the amount of medication kiosks so that people don't have to just get rid of leftover medications one time a year, but that they can do that in the future, we hope, on a 24/7 basis. In the area of prevention, doctors are now adhering to new prescriber rules, and I'll let Dr. Plavin give you some great statistics about what Blue Cross has found as a result of just 6 months of that. The state has a prescription monitoring system so that prescribers or pharmacists can check to make sure that a patient's going to be treated safely, is not seeking numerous sites of care or filling prescriptions in numerous places. We have strong messaging programs that many of you will never have seen from the Department of Health, and that's because they're targeted at specific audiences using the specific media those audiences use the most. And they can be very effective preventive strategies. We have some school-based programming, which we want to see increased, and we have community coalitions developing, like Project Vision in Rutland, that really can allow a community to pull itself out by its bootstraps and help determine what kind of community they want to be and what kind of resources that will require. And there are novel programs like a visiting program that just developed in Burlington that I'll let Brendan Del Pozo tell you about, that really tries to let those addicted to these substances know that people actually care about them and want to get them into treatment if they're willing. We have a strong set of recovery centers around Vermont, but they're unfortunately funded on a very shoestring budget. And we have a governor and a legislature who really have shown, I think, some courage and their willingness to embrace this crisis and try to really move us forward and not let us rest on our laurels. But I'm not going to deny that there are people in this room that have members of their family or friends or members of their community that have been impacted by this crisis, because every single one of us has in some way, and I'm sure that's part of the reason you're here tonight. I always like to say that we're in a marathon and not a sprint, that this is not something that goes away overnight no matter what we do. We still, over 2017, had an average of 2 Vermonters per week dying of an unintentional overdose. We still think there may be as many as 8 out of 10 people with opioid use disorder who haven't sought treatment, and wouldn't it be great if we could involve them in treatment? And we have another generation growing up that we want to make sure doesn't get afflicted by this. So now that we have this report on the hub and spoke showing how effective it is, and a report by the Governor's Opioid Coordinating Council outlining a whole bunch of strategies for the state to follow, I'll just highlight a few of the challenges that we're going to face. With regard to medication-assisted treatment, it's really making the hub experience a little more customer-friendly, I guess what the term would be, because it can be a very long wait and not as personal as some of the clients would have liked. We need more capacity in our spokes so that there are more clinicians who take more patients with this disorder. We need to try to initiate treatment as quickly as the person who seeks it wants it. And you'll hear from my colleague to the left about a program that's being started right now here in this county. We are having peer recovery coaches. Those are people who understand, have had the lived experience, piloted in several emergency departments as a way of having people brought in with an unintentional overdose, have a person to talk to, other than a physician like us here or another medical person, and somebody who has that experience and can perhaps have the kind of conversation that will profit them. In terms of recovery, as I alluded to, we need better support of our recovery centers. And recovery is really, the first day of treatment is the first day of recovery, but the most important thing about recovery is it's multidimensional. It's not just, are you avoiding the use of what you used to use and using the thing you're now supposed to use, but it's also, do you have a life? So do you have a roof over your head? Housing stability is challenging for this population, especially right after they initiate treatment. And then do you have a job that makes you feel good and makes you get up in the morning and want to go to it every day and feel productive in life? And connecting the recovery community with the employment community is a significant challenge that we're trying to reach right now. And then in the prevention arena, it's really a third of our supervisory union schools have curricula and a substance abuse professional in the school embedded, which are usually very well respected by the students and trusted, but I think we can do better than a third. We have community coalition efforts that have started in a few communities, as I mentioned, but there's no reason that any community can't do that, and they don't have to start from square one and invent the wheel, because lots of communities can give them great advice and instruction on how to do that. And then as a healthcare professional, we really need more of an armamentarium of pain management modalities. So not just medications, but if medications, non-opioid medications, and some of those we need to have research on, but also the non-medication, integrative therapy type of modes like acupuncture, chiropractic, et cetera, because not only are those sometimes very useful, unfortunately sometimes those aren't well covered by insurers, and we need to start having the kinds of quality studies that would warrant the insurer to cover them, but also more access to them. So I'm going to stop there because I've thrown a lot at you, and we have to let everyone else talk as well, and I'll be happy to interact about anything I said during the question and answer period.
Great, thank you. That was a very good overview, though. Dr. Mashkuri.
Thank you. Thanks for inviting me here tonight to speak and be with you. Ostensibly, I'm here as a healthcare provider, but I'm also a local. I live in Middlesex. I'm a parent in this community, and obviously I'm a concerned citizen like all you are. And it makes me happy to see people here concerned about what goes on in our community. I'm sorry. How's that? What I said was, thanks for inviting me here. I'm a local parent. I'm part of this community. I'm also the medical director of the emergency department, so I see a lot of what goes on with this crisis every day. I spent a lot of time thinking about what to talk about tonight, and my wife always asks me, what are you going to say? And I say, well, what should I say? And then she asks me some smart questions and gives me good advice. So all today while I was at work, I thought about this and rewrote my comments and bounced them off a couple friends, talked to the wall. Finally, they said, stop talking to the wall and leave. So I did. And I got in the car, and all I wanted to do was not think about this, just listen to some music and get here. I hit the radio, and the first thing that comes on is VPR, and it says, the maker of OxyContin is no longer going to market this drug to doctors. And I said, there it is again. I can't get away from this. And what it told me is it is. It's a crisis that affects all of us. And it's not a crisis of all of our little silos we live in. It's not a crisis of the medical community. It's not a crisis of the mental health community or the addiction services community. It's not even a crisis of another town. It's here in this community. And a community crisis requires a community solution. So I am going to tell a couple stories. I'm going to tell you what we're doing, what we hope to do. And the last thing is I'm going to shamelessly ask for help, because we're still learning how to do this, and there's a lot of good help out there in our community, and I want some of that help. We all want some of that help to make this work. Recently I was working an overnight shift, which are just terrible because you have to stay up all night. And the radio went off and said there's a 20-year-old patient in a bathtub that's empty who's blue and unresponsive and not breathing. Everyone just kept doing their business. No one stopped. No one's heart rate got elevated, because this is no longer a novel thing. This is an everyday occurrence. Paramedics got to the scene. They found the patient in the bathtub with no water, blue and unresponsive and not breathing. The patient's friends who were there said the patient had ejected something. The friends then left, which they always do, which leads me to believe maybe they're not very good friends. The paramedics gave the patient Narcan. The patient started to breathe again, brought the patient to the emergency department. I noticed when they got there, patient was breathing, conversive. The police weren't there. A lot of times they're there. They get called to these calls, but they weren't there. And I asked them, I said, where are the police? They said, they're there. I said, what for? They said, they're taking care of the kids. It was a 20-some-odd-year-old woman, mother of 3. Children at the scene were in their own home, average ages 4 months to 7 years old. They had to find someone to take care of the children before DCF could get there. So they were looking for a grandmother, an aunt, an uncle, a neighbor. That's the most dramatic presentation of somebody in crisis. But the kind of day-to-day grind doesn't really look like that. Luckily, this woman survived. She was not one of the 175 that die every day in the US from this sort of overdose. She's not one of the 2 we lose in our own state each week. And luckily, these children will have a mother if we can get her some help. What I see a lot of times is people coming in with pain that is not well explained. It's not diagnosable. A lot of bargaining will then go on to ask for ways to take care of the pain that may involve opiates through an IV, a prescription for opiates. And again, I can't find a reason to do this. Often these encounters become contentious and combative. Bargaining goes on. These are not the highlight of your day. They're tiring. And again, a lot of times it's to feed an addiction. Either somebody wants to feel better or they don't want to feel horrible from withdrawing from an opiate. Lastly, I saw a patient that came in 3 times in a week complaining of abdominal pain. Could not find out why, saw me and 2 other people. She was newly pregnant. Finally, on the 3rd visit, she confided that she was addicted to opiates. She was nervous and scared that these pills were going to do something to her unborn child. She was nervous and scared that her child was going to be taken away from her when the child was born, and she didn't know what to do. Again, I don't want to scare people or paint a depressing picture, but you've all heard the statistics. You hear them every day, just like I heard it on the radio coming down here. Half the children in the custody of the state and DCF between the ages of 0 and 5 are there because whoever's taking care of them is struggling with opiates and cannot care for them. Other things are unreported. Numerous and repeated sexual assaults against women who get most of their drugs from male dealers or male acquaintances. This is some of the things we don't hear about, yet we see all the time. So what are we going to do about this? And I think that's part of the conversation tonight, is that there is good news and there's hope. And the first thing we did, and you alluded to this, was we have to stop looking at addiction as a moral failing, a character flaw. It's a disease like anything else. It's preventable, it's treatable. But if we don't look at it through the lens of a disease, we'll never get good at treating it. So I think we all have to agree that that's the way we're going to do this, because otherwise we're not going to succeed. And we haven't succeeded, and we're making some strides now in our success to treating this problem. In the ED in Central Vermont Medical Center in 2013, my old boss, Mark Detman, real bright, forward-thinking guy, got a grant for something called SBIRT. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. At that time, we were the only emergency department in the state to receive this funding and have the program. Through the success of that program, the SBIRT program has proliferated into our Central Vermont Medical Center outpatient clinics. It's now in a number of emergency departments across the state. And what this grant did was it gave us funding and a mechanism and a framework to understand how to take care of people who were either at risk for addiction problems or struggling with addiction. And this has been a truly formative experience for our medical community. Universal screening, as some of you know, when you come to the emergency department, even if it's for a cough or a cut finger, we ask you about your use. Do you use alcohol? Do you use marijuana? Do you use opiates? Do you smoke? And we don't just leave it at that. We ask you how much, how often you use these things. And I know people get irritated sometimes, but it's for a good reason, and I'll tell you why. Universal screening is important because drinking and drugs are really common in our community, but they often go undetected, right? If no one asks, you're probably not going to tell. We know the risks of misuse of these substances. We know the safety problems, the car crashes, the loss of work, entrance into the legal system, compounding already existing health problems. And the good news is, most people, when asked, want to talk about this. They're open to change, but you gotta ask. So when you come in next time, don't get irritated when we ask you about it. We're doing it for the right reason. Critical to the success of our SBIRT program was the funding to hire SBIRT clinicians that are embedded people in our department that are there specifically to help our patients that are struggling or at risk for problems. These have been the workhorses of this program, and I know at least one of them sitting in the back. Barb, raise your hand. There she is, my savior. And because of people like Barb, we've seen success. We have found people that came in with a cut on their head because they were abusing some sort of substance, using it inappropriately, who then wanted to get treatment, who would then meet with Barb 12 times outside of the emergency department. She could be led to other treatment options in the community by some of these providers that are here tonight. It really helped us understand that this idea of addiction, this disease, is a multifaceted process. It is not easy to understand, it is not easy to treat, and it made us realize that the way we've been doing things for a long time were not right, and we needed to adopt different strategies. And thankfully we did. When Mark asked me to work and head up the SBIRT program, I panicked because I realized I had no idea what to do. So the first thing I did was I called Bob Purvis on the phone one day and said, hey, can you come here and talk to me and tell me what this looks like in our community? Who's out there to help us? What do we do? We got a couple other friends, and we started a collaborative of all the substance abuse services in Washington County, and we created something called WICSARP, which is Washington County Substance Abuse Regional Partnership. And we all sat around a table every month and talked about what the problems were, what services we had, what services we didn't have, and how we could work together to create pathways to help people navigate through this sort of complex maze of systems to get help. And again, this has been tremendously helpful to have good friends like this that can help us get through all this. And what we learned was, if we want to be successful at treating this, we have to meet people where they are. That could be in the emergency department. When they're ready, they're ready. They've just had a horrendous car crash. They've just done something, and they said, you know what, I need help. And we got to be there to help them. We got to have a way to help them. It could be in their doctor's office. It could be at their housing specialist's office. It could be anywhere. And that's what this idea has to look like, and that's what we have to strive for. One of the things we realized when we had this group was we realized there was no system for someone that wanted to detox from alcohol to do it as an outpatient. So with the help of Mary Moulton and our friends at Washington County, our designated agency, we created that. People can now come to the emergency department and we can get them somewhere that doesn't require an inpatient stay in the hospital. But it wasn't easy. It took about, 2.5 years to get there. So again,
30.
30 years, yes, that's right. When I met you, you said 30. We learned how to collaborate with our local addiction specialists and with our local law enforcement. You'll hear more talk later from Deb and Chief Fakos about the Project Safe Catch, where you can present to the local law enforcement and ask for help, and the help is there. We have to continue this process because, as I told you, a lot of people come in, they don't say, I'm addicted, I have a problem. So we have to screen, we have to ask. Not everyone's going to come in dramatic fashion of an unintentional overdose. There are laws in place now that now sort of legislate how we approach opiate prescribing. And this has done two things. Initially, my colleagues were mad because they said, the government should not tell me how to practice medicine. I'm offended. Get over your offense and move on. And understand that now we feel that the public's been educated about how horrendous some of these medications that we prescribe are, how when used judiciously and effectively, they can help you. But when not used judiciously and effective, they can harm you, they can ruin your life. So now it's incumbent upon us, we educate patients about what opiates are. We talk about, instead of giving opiates, we use IV Tylenol, IV ibuprofen, other methods of pain control not involving opiates. We ask that we give you information. We make you sign a consent form to actually receive a prescription for opiates from us. And we go through what all the downsides are and what the potential upsides are. One thing you have to remember is that, unfortunately today, the majority of people that are addicted to heroin started with prescription opiate drugs. So we have to educate the public, say, look, we're going to decrease your pain. It's probably not going to go away. There will still be some pain left, but we're going to get you feeling better so you can function. If you remember one thing tonight out of all the things we've talked about, most people, when they receive a prescription for pain medication, do not finish it. Don't keep that in your medicine box. Dispose of it safely so it doesn't get into the hands of the wrong people. When you're done using it, be done with it and get rid of it. Don't keep them. The laws have, and I think Josh can talk about this, in terms of prescribing, we saw 2,100 patients in the emergency department a couple months ago. That's about what we see every month. Out of those 2,100 patients, how many patients left with a prescription for an opiate? This is group participation. Someone yell out an answer. 80? Anybody else? 1,000. Very close. 45. 2% of people leave with prescriptions for opiates. We are very, very cautious in how we prescribe these medications, and with good reason. Now. The last thing we're looking at is this idea of timely treatment. So someone comes to the emergency department and they're struggling with opiates and they want treatment. In the past, it's been somewhat of a struggle to get them to the right place to start treatment. What we are proposing is to train emergency department physicians and providers how to start that treatment when the patient's ready, to meet them when they're ready. We call this medically assisted therapy, but as my colleague here said, it should be ready access treatment. Because when patients are ready, we should not have barriers or hoops for them to jump through. We should help them get the help they need. I've been working with Bob Purvis on this and a ton of people in this room about how we can do this, how we can get peer recovery coaches into our emergency department to have yet another tool to help people fight addiction. So lastly, I would ask for your help. I've learned a lot about the synergistic power of collaboration with community partners. The medical community tends to keep itself in a silo, but we're making those walls crumble now. And we're working with all kinds of partners across all different disciplines to attack a disease that's multifaceted, and so far, with just traditional sort of medical therapy, has been difficult to I can't say cure, but to help. So I need help from people in the community that have ideas, skill sets, sweat equity, money if you got it, intellectual interest, because we're not going to do this alone, and this community crisis requires community participation. And I'm proud to be part of this community, and I'm proud to try to help, but I don't have all the ideas, I don't have the answers, but I know I have a lot of people out here that certainly do. So I think I've gone well past my allotted time, so I'm going to stop there. Thank you.
Thank you very much, and you went well past your allotted time. You both did, so shame on you both. And cautionary tale to the rest of you, I'm going to start pounding on the podium when we get to about 7 minutes. So let's keep it moving, otherwise we may not be out here until 11 or 12, and the rental only goes till 9. So, Dr. Plavin.
Thanks. So I'm Josh Plavin. I've been a primary care provider for almost 20 years in Vermont. I've been a ER doc. I've been a MAT spoke provider. And for the past couple of years, I've been at Blue Cross Blue Shield Vermont. This is not a new problem. This is a magnification of a long-held problem. Back in 2002, Blue Cross sponsored Bess O'Brien's film Here Today, and we did community talks throughout the state on the heroin epidemic, which I was living through in Chelsea when I was a primary care provider there. And then we sponsored the Voices Project after that, which was a workshop with the Vermont teens. And then in 2013, we sponsored The Hungry Heart, which was about the opioid epidemic caused by prescription drugs. 3 out of 4 people who use heroin started with prescription drugs. So this is the medical community's contribution to this epidemic is significant. We can't shy away from that, it's significant. And one of the things that we've been trying to do at Blue Cross is to raise awareness, public education, prevention, supporting SBIRT, looking at alternatives to chronic pain treatment, and supporting the hub and spoke system. And I do have some good news through all this, because we have access to our claims data. And we've been monitoring the prescriptions of opioids before and after the institution of the rule, so I'll cut to the quick here. I will note, though, interestingly, that raising awareness is a big piece of it. Public awareness is very important. And Governor Shumlin, when he announced the opioid epidemic in the state of the state in 2013, did have an effect. And even between 2013 and 16, we saw a 27% decrease in the prescription of opioid medications, even before we did any rules or regulations. Then we started to work with the Department of Health and then Commissioner Chen at the time with multiple different payers, prescribers, and a large work group to initiate these rules. We initiated the rules in July of 2017, and these rules had put a limit on acute opioid prescriptions to no more than 7 days for adults and 3 days for kids, and had some other issues like not starting new patients on long-acting opioids, et cetera. What we saw soon after the initiation of the rules, and after we operationalized that within our system, so that there was a stop at the pharmacy, that we saw a 25% additional drop in opioid prescriptions. That equals 672,000 fewer pills available per year in Vermont. So all told, from 2013 to now, we've seen a 48.8% decrease in the prescription of opioids from our network providers, our members. Concomitant with the rules, we also supported the use of and the prescription of naloxone to help to prevent overdose deaths. We actually do a fair amount of work with our providers, identifying members who might be at risk of overdose and suggesting using this medication. And we've also seen a 219% increase in the prescription of naloxone in the population, which is very heartening. So the work that was done recently has had an effect in terms of mitigating the availability of prescription opioids available, but it's not enough. As you know, it's going to take multiple different venues to address this problem. And we are looking at different ways to treat pain, because pain's not going away. We now are learning that opioids are probably not a good treatment for pain chronically. They're fine for a day or two, but even a day or two puts you at risk. And so we are supporting the development of some new alternatives. We have been supporting cognitive behavioral therapy as treatment, PT, Chiro. We're looking very closely at acupuncture. We're developing in concert with UVM Medical Center and Barre Retreat 2 new integrative complex pain clinics, which would include yoga, massage, mindfulness, acupuncture, as part of a treatment regimen. And we hope to scale that up throughout the state over time. And those kinds of interventions have been shown to be helpful for the treatment of chronic pain. And in the ER, as Javan said, the use of Tylenol and ibuprofen have been shown to be as effective as opioids. And so transitioning to alternative treatments from a pharmacological perspective is probably a good idea. So I think I've kind of used up my time. I'm not going to go too long. I think I hit my maybe 5 minutes here. But I'm happy to answer any questions you might have when we get there. So thanks.
Great. Mary?
Thanks, Josh. Thank you. Hi, I'm Mary Moulton, Executive Director at Washington County Mental Health Services. Steve had asked us to kind of look through our lens at what we see with this epidemic. And at Washington County Mental Health, we see people from birth to death. So we have very much seen an increase in substance use in our adult population with serious mental illness, in people coming through our doors for outpatient therapy, for adults with intellectual disabilities who are also using substances that they never used to use before. Certainly in our emergency services where we do outreach, in fact, most all of our programs are outreach into the community. So when Javed says meet people where they're at, we may be going into a home, seeing that there's a parent that's trying to get them hooked up into medication-assisted treatment, and the sooner we can do that, the better. So it's really all about partnerships, and this is what we're talking more and more about all the time. Partnerships with Central Vermont Substance Abuse, with your school system, with our emergency room, with our insurers, with our police. I mean, we have got to be having partnerships out there all the time. And one group I want to talk about, which are the recipients of this addiction problem, are our kids, our children and families. So when I put the question out to my staff and said, you know, where are you really seeing this hitting hard? My children's division just was hollering back, we have so many children that are experiencing trauma because of their parents' addiction. Their parents are not able to be present for them. When they're little ones, 0 through 5, that's where we're seeing kids going into DCF custody. We need to have more helpers out there to help parents with their addictions, really in the community, in their own homes, wrapping them up tighter. And we don't have enough workforce for that. So we get back to our workforce issue here. But we have children that are experiencing the trauma that are not available when they come to school for learning because they're not sleeping at night. You know, the case that Javed talked about where the mom came in and the police, you know, stayed with the family. We see that in our community. We are so fortunate. I cannot tell you how fortunate. My emergency services team speaks about the police that will stay, that will make a meal for the family, or wives will make a meal for a family or husbands while their police officer spouse is on the job. This has actually happened in our community for kids while waiting for DCF. So we are incredibly fortunate in our community with that, but the child still is experiencing trauma. So we when we talk about what we can do as a community, and I'm a member of our community, it's how do we create safe neighborhoods? How do we get more housing for moms who are addicted? Affordable housing. Affordable housing is extremely difficult to find. And so we need to have more housing. We need to have transportation to childcare and childcare to take these kids. Some of these kids were born addicted, and so they may have attachment issues, definite deficits in school that need to be addressed, so they need extra help as well. So, I just wanted to speak mainly on the kind of the victims as well of the addiction, that we sometimes, as we talk about the things we are doing, which are very, very good things, it's a ripple. It's like a pebble in the water, and it ripples out. And so we have another whole job to do with children and families, and we need people to be able to be in our workforce to do that. So workforce issues are definitely prevalent for us. We need more therapists. I also would like to just put out the idea of safe baby courts. This is something that has been working in some communities. Similar to treatment court, there are safe baby courts. And when a child is born and a mother has some charges, going to court, you actually can have a court that helps bring all the providers together, because we need to do a much better job as providers with communicating so that we can get the services in for people. And if there's a court situation going on, you can have providers actually go to the court to help wrap a mom, a family with these services to give an optimal opportunity for success, perhaps, at keeping their child. The one thing that we do have in our community that works really well is our community response team. And that's a group of providers that comes together from mental health, substance abuse, the OB office, women's health. Many providers, when we do have a challenging case, they meet regularly, bring these cases to the table, and then they're able to plug the services in for children and moms for addicted families. So the Central Vermont Community Response Team is a very good model in our community for bringing providers together and getting services. But again, we're experiencing a wait list to get kids into early childhood programming and all that ripple effect from the opiate crisis. So lots more to do, lots of opportunities, and I'm really enjoying the partnerships that we're experiencing when we talk about on-demand treatment, when we talk about developing housing opportunities, and any ideas that you have, please come forth with those, because we are really talking about how we respond as a community. Thank you.
Thank you very much. Ann.
Hi, I'm Ann Gilbert, Director of Central Vermont New Directions Coalition here in Montpelier, and thank you, Stephen, for arranging this and for everybody to come out and talk about this. Our mission at our community coalition is to increase healthy behavior and decrease substance use. And one of the main ways we do that is through community partnerships, really connecting with other people to make these things happen, because we can't really focus on prevention without many, many hands. Prevention is one part of the continuum of intervention and treatment and recovery and enforcement. But I see this whole crisis in a different lens, because I'm looking at it really from preventing it from happening in the first place. How do we stop it so we don't even get to the hospital or the, a crisis at school or kids being taken away? So prevention is really stopping something before it happens. And we learn from mistakes, we learn from data and science and experience. And so there are many things that we have right now as a result of that, like seat belts and helmets and child-proof lids on packages, floss and vaccines that we've had for polio, and even the flu shot. And I think the flu shot's a good measure, because it's one of those things that everybody knows that we're going to be able to prevent that. And how do you know? Because you hear about this everywhere, from your doctors, from your parents, from other parents. There's signs, the pharmacies, the health department. It's on TV, it's on the radio all the time. Get your flu shot, wash your hands, don't get the flu. So that's kind of what we need to prevent some of what's going on here. And one way to do that is to really back it up and look at where does it all start? If if so many heroin users started with prescription drugs, I think we can know that so much of the addiction, even at that stage, did not start there. It started with a problem behavior way before that. And that's where we're really trying to address preventing substances, all substances, in families, in communities, and with kids. You know, anywhere from flavored vaping, nicotine products, tobacco use, underage drinking, binge drinking, marijuana, moving on to pills, and then moving on to heroin. So there's really such a wide array, and that's really what we're trying to address at the prevention level. We do that by working with law enforcement and with medical providers, with the schools. There's some leadership groups in the schools. There's students like Students Against Destructive Decisions, who are really doing a lot more peer leadership among their kids, because we really need to have more people more informed about what they can do. The media has been a big help as well. In fact, we're using a Vermont Department of Health media campaign called Vermont's Most Dangerous Leftovers. This is really promoting some simple practice of safe use, safe storage, and safe disposal. So we want kids to know this message, and even new moms that have newborns or toddlers to start practicing this in their families and modeling this so that the kids understand how important it is to read the labels. What is an over-the-counter medication compared to a prescription drug? Not taking a prescription that's not prescribed to you. Only using the correct dosage. Not just opening the drawer and grabbing a teaspoon or a tablespoon for a liquid medicine, but treating it like you were making a really important recipe and really following the guidelines. Safe storage, locking up your medicine, keeping it out of reach of toddlers and pets, putting it away if you have people looking at your home if they want to buy it, or if you have a babysitter coming in, or teens, or friends, or family visitors. And then safe disposal. So we now have partnered with all the law enforcement in Washington County, and there is a permanent drop box, like we heard, in every police station. So when you're taking your trash to the dump or recycling, you can take old pills or medications right to a police station and drop them right into the box. You don't have to wait for the 2 times a year drug take-back day. And this is a better system than flushing it down the drain or putting it in the compost or into the landfill. So we're looking at all substances, and we're looking at all people in the community to really play a part in this. You know, it is a problem in Vermont. We have 18 to 25-year-olds that have higher than the national rate use of prescription drugs and of heroin. And when we look at our high school age kids, on the Youth Risk Behavior Survey that they fill out every 2 years, we find that in Washington County, some of our schools are at the state level of using a prescription drug not prescribed to them in the past 30 days, but that there are schools right here where it's double. We really need to pay attention to that. So my message is you can take action. Everybody can help with this. Prevention's very important, and prevention is continuous, kind of like a marathon or an ultra marathon. Every year, there's a new crop of 4th and 5th graders that are getting ready to move on to middle school, where a lot of different behavior and different opportunities, different trouble takes place. And often there's a new trendy substance that comes about, whether it's a new flavor in vaping or a THC edible. So my message is to start early, start at home, give information to your family, talk about it often. You know how many times you have to tell your kids to do something, so this might follow the same thing. And practice safe use, safe storage, and safe disposal. And I do have a few pill pods in the back where you can lock up medications if you don't have a locking medicine cabinet at home. There's also a sign-up sheet if you'd like to be on our e-news list for our community coalition, or if there's some way that you might like to help out. Thank you.
Thank you. Chief.
Thank you. When Mayor Murrow Weinberger asked me to help lead Burlington's response to the opioid crisis, I ended up going down a rabbit hole of giving up my conference room to a 30-year social worker and service provider, hiring an opioid data analyst, going to the UPenn Medical Center. I just got back from the Johns Hopkins Bloomberg School of Public Health, and I asked myself, am I still a chief of police or am I a public health researcher? And then I'm sitting here next to public health clinicians looking at my police colleagues down there, and my identity crisis is actually quite profound. I assure you this is just because I have yet another engagement back in Burlington at about 8:30, but it doesn't help actually to look down and see that I should have worn a uniform. I'd feel more confident about my identity.
You're going to have to drive really fast.
I'll tell you, 8:30, oh. No, it's, we have time, come on. So, and the state police are here. So. Anyway, so all of that said, listen, I got to say though, we can use a dose. Oh, so by the way, if you don't know, I'm not from Vermont, and I get reminded of that very lovingly at least once a day. But you can learn something from the manic, like Tyrannosaurus Rex-like focus and rage of the New York City Police Department when it comes to attacking a problem. And that's, to my perspective, the nation's response to the opioid crisis is unfolding at really a maddeningly slow pace. We have 60,000 people, give or take, who died of drug overdoses last year. If this was a war, it would be like fighting the entire Vietnam War every year and losing the same amount of people every year. It would be like taking the 82nd Airborne Division, the 101st Airborne Division, and the 1st Infantry Division, sending them all off to war and having all of them killed, every single one, every year. If that was happening politically in some other way than the opioid crisis, none of us would stand for this. The chief of the commissioner of the Baltimore Police Department was just fired for not bringing the homicide rate under control in Baltimore. I think the problem with the opioid crisis, to be candid, is we don't know who to fire for not reacting more swiftly. And I know that, I'll tell you, if I was presiding over a crime crisis like this in Burlington and the mayor handed me my walking papers, I couldn't possibly object. So one of the things I'd urge is that people bring a real sense of urgency and focus. And one of the things that I've learned from public health is that the goal here is to reduce morbidity and mortality, and that if the current infrastructure can't do it, then you have to be a little more urgent, a little more coarse. One of the things that public health focuses on is population-level interventions that reduce mortality. What does that mean to a cop? If I had a violence crisis or a robbery crisis happening in one neighborhood, I put a cop on each corner for all the hours that the sun was up and even after the sun was down, and you'd say, well, you're not going to catch the crime that's happening indoors. You're not going to catch the crime that's happening down a particular alleyway, or there's things happening in apartments you're missing. No, but we would, in our imperfect and effective way, for example, suppress street-level crime at that location. What does that mean for opioids? Well, we'll start with the AIDS epidemic. Think of condoms. One of the responses during the height of the AIDS epidemic was to give out millions and millions of condoms, right? And people said, well, that's not stopping certain types of behavior. It's not going to catch all of the behavior that we're looking to catch. Some people aren't going to have one handy. We didn't let the perfect be the enemy of the good in giving out millions of condoms until we could find the cocktail that served to suppress the HIV virus. But we knew it was a population-level intervention. Cholera, what do they do to fight cholera? They don't say to people, they don't scold people for drinking dirty water. They don't say, don't touch your feces, and if you do, you're going to have to suffer the consequences. They give out millions and millions of bottles of water and say, just drink this water. We're going to drop it by helicopter until we can bring this under control. It doesn't reach everybody. Some people it misses. The latrines that they give out don't work for everybody, but it's a population-level intervention that brings things under control. Potassium iodide is what they give out when there's a worry about radiation exposure in a community. So these are all, again, population-level interventions that help bring an epidemic or an exposure under control. A lot of the long-term solutions that we talk about are very important. Jobs, shelter, skills. I'm not discrediting any of them. I'm just saying 60,000 people have died. We've got to do something a little more quickly. So one of the things I urge that you can do as Vermonters is to hold us, everyone here, the gentlemen and ladies in policing, in public health, in medicine, hold us accountable for giving you evidence-based interventions that are effective and that we implement very quickly without delay. They've got to be evidence-based. What does that mean? If they're evidence-based and they're working, the number of people dying should start to go down. It means we're bringing it under control, right? There's a few other evidence-based things that you should be looking for. In my opinion, this is number one, that opioid prescribing levels return to pre-epidemic levels. This requires transparency about how many opioids are being delivered to Vermonters. It might require opening up the Vermont prescription monitoring system, not to look at the amount of pills that Dr. Levine himself is prescribing, but at the right level of de-identification to be sure that the government and the public health people in the hospital are pushing fewer and fewer opioids out into the population. We have a monitoring system that will tell you down to the pill what's getting out there, and the law is written so that all of us have absolutely no access to it. That is not the right response to an epidemic. Second thing, number of people receiving medication for a response to their opioid overdose. Abstinence does not work. Buprenorphine, I've come to believe after researching this till I want to stab myself in the eyes, is that methadone and buprenorphine work to address this chronic condition. Just giving out buprenorphine alone with no counseling, no wraparound services, no job, no shelter, no nothing, will keep at least 80% of the people using it completely free of heroin and opioids for at least 12 weeks, and that's just as long as the trial runs. That's better than nothing. If you can't get someone into a bespoke or properly done or comprehensive treatment plan, just giving out the drugs. If you ask folks that are struggling with opioid overdoses, just getting the drugs is 80% of what they need. And I know that that's not perfect, but let's not let the perfect be the enemy of the good. Another thing I'll say is medication-assisted therapy in prison. If you are desperate enough to commit a burglary or a robbery or a car break or to traffic somebody to get your opioid fix and you wind up in prison, you're somebody that's not only in danger of dying, but you're in danger of infecting other people with opioid use, especially if you're dealing, and you're also having other negative effects on the community. If we ask, and this is not, our corrections folks are very, very conscientious, hardworking people, and they're on top of this, but I do say, if we were to say that we're going to judge the effectiveness of a warden or a correction official on the recidivism rate of their prison population, they would be in Montpelier demanding medication-assisted therapy in prison now, and we'd have it in every state in the country. And the last thing is we have to look at every possible place to induct people into treatment, primarily medication-assisted, evidence-driven treatment. It could be the needle exchange, it could be the hospital at the emergency department level, it could be police departments, fire departments. Every place in Vermont has to be a vector towards getting people into the right type of treatment. So I guess I'll close by saying I was never, when I was young, I was a fan of World War II history because my grandfather was a paratrooper in the 82nd Airborne, and then I thought, oh, I grew up and I got away from that. But I've actually returned to World War II history to see how our nation deals with crises and resolves them in a matter of years and not decades. And I never thought that I'd say this, but I think General George S. Patton has a lesson for us. And he said, a plan violently executed today is better than a perfect plan executed next week. And I think that's what we have to keep in mind. So we want to keep our eyes on the long-term goal of the right type of treatment, but if the rate of death persists as it does, we need a good plan violently executed today. That's medication-assisted therapy, and that's given out with very, very, very low barriers, and that's that Vermonters demand that people pursue evidence-based responses to this crisis. Thank you very much.
Thank you. Hi, my name is Bob Purvis. I'm the director of the Turning Point Center in Barre, and I'm a person in long-term recovery, which for me means that I haven't had to take a drink or a drug in 13 years and 9 months. And as a result, my life has been incredibly better than I could have imagined, and I'm a responsible member of the community. I say that not for any kind of applause or anything, which I didn't get anyway, but to help do my share to kind of reduce the stigma. Stigma is still a huge problem, a huge barrier, both to treatment and recovery. I want to give a thank you to Dr. Levine for the nice things he said about the recovery centers and our needs. We're our shoestring budget is such that I wear loafers these days. So for those who don't know, I'll just give you just a brief idea what a recovery center is. There are 12 recovery centers in Vermont, and our mission is to support people in getting into recovery and getting healthy. And we do that through providing peer supports, which means a person who's been through addiction and recovery supporting another person who's trying to do the same thing. And we are trained and learn how to ask the powerful questions that can help a person identify what their needs and wants are, what the vision for their life is, and then we support them in getting it. That's what we call a recovery coach. That's the highest form of service that we have. And as Javed mentioned, we're about to have recovery coaches in the ED here at CVMC, and I'm really looking forward to getting that underway. We have, in addition to peer supports, we do educational programs, everything from exercise yoga to writing groups to workshops on recovery. What's entailed in recovery? What are the 12-step groups about? Are you interested in possibly in that or not? And also we have recovery groups. We have what we call an all-recovery meeting, which is a recovery support group for people that supports people on all pathways to recovery. Now, we're also a safe place for recreation and social events. So back in early 2013, the Vermont Recovery Network, which is an organization that we formed to help support our statewide activities as recovery centers, we could see the hub and spoke system was going to be coming into effect. And we envisioned all of these people with opioid addictions who would be getting into medication-assisted treatment and then would have really nowhere else to go from there, or not know where to go from there, and they'd be kind of bumping into each other on the street. And so we proposed to SAMHSA, the federal government, that we would create a statewide recovery system for people in medication-assisted treatment. And we did that. We got the grant, and we created what we call the Pathways to Recovery program. And we have what we call a pathway guide who works out of each recovery center to connect with the local hub, the regional induction center and support center for people on medication, and also to connect with the spokes, which are the doctors and the clinics, which also prescribe medication. And I have to say that I've been director of my recovery center for about 7 years now, and my life has been totally changed by the opioid crisis. You know, opioid addiction is unique in certain respects in terms of the powerful nature of the cravings, of the way the person becomes obsessed with the drugs because of the pain of withdrawal, and of the fact that when you go down the food chain in addiction to opioids, you end up committing crimes. And you're not a criminal, but you're committing crimes. And so you face imprisonment and you face death if you have happened to take fentanyl by accident. So we have two things that we haven't really had before with people who are trying to be in recovery, which is, it used to be you could say, well, maybe he's not ready yet. We'll see him again in a few months maybe or a year. But with opioid crisis, it's a total different, the stakes are so much higher because now we have prison or death being two of the more dramatic but foreseeable consequences of not getting into recovery. You know, the importance of the recovery centers is that we are the long haul. The treatment is a short-term intervention. Now, you may be on medication for the rest of your life, or you may be on it for years, but in either case, you're eventually going to be getting prescriptions from a family doctor, and you won't have the same supports at the clinic that you start off with. So what do? Well, you know, the best research says that long-term recovery doesn't start until you have 5 years of continuous recovery. And at that point, you have about an 85% chance of remaining abstinent or in recovery for the rest of your life. This is a long process. And so what do people do? Well, we're what they do. They come to talk to us. They come to hang out. They come to be with other people in recovery, to become part of a community that supports each other in recovery. And that's a very powerful force. It's as powerful as the peer pressure that leads people into using. The peer supports can be just as powerful if they connect. Well, there's a problem for people on medication. They suffer not only the stigma of addiction and sometimes of having a criminal history, they also suffer the stigma of being looked down upon by many people in the 12-step community because they're not considered to be clean. At the Turning Point Centers and all of the recovery centers, we pursue an all pathways to recovery approach. We believe that we don't measure people by what they need to take by way of a medication to support their abstinence. We take them by what they do for their recovery. What steps are they taking to change their lives? We accept anybody who is doing the same things that everybody else does in recovery. And many of those people are on medication. Some of them will eventually get off, some will remain on for the rest of their life, but damn it, they're not dying in the process. And as long as a person's alive, they have the chance of getting into recovery. I mean, recovery is a whole lot more than abstinence. And people who get into it, they sometimes look back a few years later and say, boy, if I'd known that this much was involved, I never would have done this, you know. But the fact is that every day that you're in recovery, your life gets a little bit better. No, I changed that, and that's not what I mean. Your life doesn't get better necessarily, but you get better at handling your life. And that's what recovery really is about. Okay, so I have some pamphlets with me, and one of them shows that after the 3 years of the federal grant we had data collection, of course, for that. And we were able to show increases in recovery capital for people between their intake and 6 months later that connected with us. Their housing has improved measurably, and their abstinence is reduced. I mean, their abstinence is increased measurably as well. So it's, you know, we have an employment, another biggie. People's employment levels go up substantially after 6 months, even after 6 months. So we're still doing it. We're now into our 5th year of this program, and it looks like it's going to be fully funded next year, which means that it's going to even be better. But the key thing is that the clinics are terrific, and I know the people up there, and I know the people working at the clinics, and the MAT teams. These are all terrific people who are working very hard, but they simply can't. You know, when the person walks out the door, they can't go with them, and so that's where we are. And we hope to stay there. It's a really challenging time. People getting into opiate recovery have often more obstacles to recovery and a tougher road than people, say, with alcohol or even crack or some other drugs. And so the need for support is even greater. And we hope to be there over the long haul, to be there with them. So,
Thank you. And thank you to this first panel for We're going to take a minute, and if there are questions, folks should come up here. We're only going to take a few questions because we don't have a lot of time. So if anybody has any questions, looks like Beth has a question.
Thank you all for being here. Is this on?
Yes.
Yeah, okay, thank you all for being here. I'm the director of Central Vermont Council on Aging, and you've spoken about children, and I wonder if somebody can speak to the effect that this is having on the older population, not only directly, but how they interact with their families.
Anyone?
I can tell you that there's a special initiative underway right now to address the older population because it is currently not addressed very well at all. Older people tend to be more isolated to start with, and they tend to withdraw even more when they begin to have problems with alcohol and opiates and other drugs. And so a lot more outreach is needed to find these people because they're not out in many of the usual places that we encounter. And they also need to be, we do a better job of identifying them, like with Meals on Wheels and people from agencies who go into their homes and or home health hospice, whoever that goes in to help be trained to identify the signs and try to connect them with some help. And we're trying to train more older recovery coaches who would be in a position to, say, go in. I mean, our place is right near North Berry Manor. And so I've connected with the SASH worker there. And when there's somebody, you know, who is perhaps interested, then I'll meet with them. But the supports generally aren't there very well for them.
Anyone else?
I would just add that when you look at the statistics on these disorders, the peak ages tend to be the early 20s through the mid to late 40s. But that doesn't mean there's zero beyond that. And there is still a reasonable population of people who are certainly over 55 who more quietly, I would agree, have this disorder. The fact of the matter is that as one gets older, arthritis and other aches and pains occur, so the likelihood of opioid prescribing can actually go up in that population, and the assumption that it would be safe can be a false assumption. So I think just like And all other times that we prescribe opioids, we recognize that we have to be careful across the spectrum. It also adds more relevance to one of Governor Scott's requests of Congress when he went to Washington, which is to have Medicare fund the medication-assisted treatment programs in the same way that our Medicaid system does, because currently it does not. And we know that in our hub-and-spoke system, there are probably around, well, it's hard to estimate, but certainly somewhere in the 500 to 1,000 range Vermonters that have Medicare.
Great.
I agree with that. I do think that, as everyone said, that the elder population certainly is underreported and underrepresented when we look at our expert data. I also think that what we're seeing now, and again, I don't know if it's figures, is that another generation of people are becoming caretakers for some of these children and stuff as families, extended families now participate in the care of these children if the parents are not able to do that. And I think that plays a significant role in the crisis as well.
Hi, my name's Cheryl Vince. I wanted to ask Dr. Plavin, you spoke about the reduction in prescribing. I didn't know if it was new prescriptions or cutting off people who already had prescriptions. And when there were those reductions, where did those people go? And isn't that a provocation to turn to heroin? So how do you balance these two?
The reduction was predominantly in new prescriptions to opioid naive, if you will, patients, but that's a risk in and of itself. There are some good studies to suggest that people post-operatively need maybe 3 to 5 pills, and they're often prescribed 45 to 90. So a lot of the numbers are in that pool, not the chronic.
So not the chronic out-of-hospital prescribing.
Right. But that would also, if 70% of the abused prescription opioids are sourced from family and friends, it's those extra pills that put people on the wrong road.
Thanks.
Let's take one more question. Yep,
me?
it's you.
My name's Leah Jones. I live in Montpelier, and I have seen friends struggle through this addiction and family members. But the lens that I'm looking through it now is that I have 3 little boys, and my husband and I are doing our best to work on the side of prevention. And I'm wondering if any of you can talk more about the aspect of this. You've talked a lot about how the drugs are prescribed to treat pain, and that's often how people become addicted. Can you talk about teaching children how to deal with not just physical pain, but emotional pain, which my understanding is that a lot of people take drugs to quell that kind of pain too. Can you talk about how parents can prepare their children to better sit with emotional pain and not look for substances to help with that?
Well, I think one of the challenges we have within our society, and we talk about this a lot amongst ourselves, is that there are so many diversions that are natural for children to access, whether it be the quick TV or the device. And so just talking about coping, honestly, with your children, talking about hard times, talking about the struggles that we have in life, and having honest conversations. We just had a death in our family, and talking to our 4 to 6-year-olds around what that meant and how sad that was, and have them experience some ritual with that, and that this is part of life. Life is not easy. We did a community forum in Montpelier this past year about mental health crisis, and I remember somebody saying, just the whole experience of life is so hard. Being human is really traumatic. Well, being human is hard, and I think we do our kids a disservice if we just don't talk honestly about that and give them the opportunity to experience difficult times and walk them through it. So I think being honest and thinking about where they are developmentally and trying to access good books and conversations is the best thing we could do for our kids.
I'm going to shamelessly advertise a website that you can access through the health department, but it's called Parent Up Vermont. And it's really a website tool for parents who never thought they'd have to have the conversations they're about to have with their kids and want to figure out ways to have those conversations in a productive way. So things on there such as, I think my teen is drinking or doing drugs. I know my teen is drinking or doing drugs. I'm concerned about my teen's mental health. My teen needs help now. There's a whole host of videos and examples and tips on how to start having conversations like that. So I just recommend you take a look at it.
That's a good idea. That's Parent Up website. And also, we have a parenting class called Guiding Good Choices. And one of the things that we cover with that, even with older, a little bit older, but even for the young kids, is, you know, family dinners and family time and talking about your high and your low of the day, and that it's okay to have low times, and what can you do to help yourself feel better, and modeling, like, what do you do to make yourself feel better? You know, I mean, there are a lot of parents who might say, oh, I've had a rough day, I've got to have a drink, or I've got to have a cigarette, or, you know, and I've got to take something for that. And kids are watching. They're watching all the time. So, you know, I think it's important for parents to recognize that and just be a little bit more careful about what they're modeling. And always encouraging kids to have at least 3 helping grown-ups. So the beginning of every school year, or, you know, at different times, maybe on their birthday, you could say, can you tell me who your helping grown-ups are? If you had a problem, if something happened or you didn't feel good, who would you want to talk to about that? And it might be you as a parent, it might be a friend's parent, or a teacher, or an aunt or an uncle. But it's good for them to keep up that list and reevaluate that several times a year so that they always know that there's somebody they can go to without having to hold that in.
Okay, we're going to swap out the panel, so stay tuned for wait just a moment. If everybody could take a seat. I'm actually going to go in reverse order this time because we were focusing on public health before, and we've got a couple more folks who are in the public health realm. So I'm going to start on the other end briefly, and then we'll come back to law enforcement. Great. So Evan.
Sure. Hi there. My name's Evan Smith. I am a licensed clinical social worker up at Central Vermont Medical Center. I oversee the medication-assisted treatment spoke services for the hub and spoke in our hospital service area. So, it's pretty much all of Washington County. I want to kind of just give you a general idea of, how many people we're serving in the hub and spokes. Right now, the census up at Central Vermont Addictions Medicine, where folks are dosed with medication up to on a daily basis, we have about 454 people there being served. That number has actually grown significantly over the last couple of years. I think that would tell us that we had about 150 people a little over 2 years ago. So, that's a pretty significant growth of folks coming in and being able to access those services.
Can you just restate that? How many folks are being treated daily?
So, the hub is serving 454 people right now. And we are also serving 443 people in our spokes. And, when we talk about spokes, you heard a little bit earlier, that's traditionally primary care practices. But we also have a number of specialty providers here in the state, or in our region. Dr. Rappaport, who works up at the spoke, up the hub, also works with CVSCS and their spoke, and Treatment Associates, another provider here in Montpelier. Dr. Stone and Stu Williams are two doctors who are actually providing about 50% of the medication-assisted treatment in our community. And I think it's really important to recognize, the benefit of having these folks working with us and being able to prescribe this medication. In all, there are 15 different healthcare providers prescribing medication-assisted treatment in our community right now. I know we've been talking about, the need to increase that, as Dr. Levine had said, but we actually have doctors right now in our community who are saying, Evan, give me more referrals. I want more people to come forward. And, we're doing that. I'd say at this point in time, when we look at the numbers, we're seeing probably between 8 and 12 people coming into either the hub and spoke on a monthly basis in our community. So, people are still coming forward, and I think that's an important thing to recognize. It's really important that people have those services available to them when they need them and want them. And that's one of the biggest challenges I think we're up against, is getting people when they're ready and want this service. And so, honestly, I do think our community has done quite a good job. We're recognized throughout the state of being one of the better coordinated communities in terms of being able to offer and provide these types of services. And I think it's in some levels, although we have ways to go, it's something that we can be proud of. Mm-hmm. One of the things that I had heard when Dr. Levine was speaking, he was talking about, 8 out of 10 people aren't being identified. And if we just do those numbers, I gave you numbers on our census in the hub and spoke. That's about 1,000 people. Mm-hmm. So if he's saying 8 out of 10, that means we probably have another 4,000 people out there in our community who are not getting services right now or wanting service. And that's one of our biggest challenges. How do we get those people who are not ready and wanting these services to come forward? And I don't necessarily have an easy and quick answer for that. But the importance of being able to have family, friends, and people who matter in their lives, be able to let them know that there is help available and that people care is really, really critical. And I think it's something we all have a responsibility to continue to do and reach out to those loved ones that we care about and let them know that there is help.
Thank you.
Sure.
Deborah.
Hi, I'm Deborah Hopkins from Central Vermont Substance Abuse Services, and we are very much like the previous panel. We are a provider of services. We do outpatient services. We do work with Dr. Rappaport with some folks around Spoke. What we primarily do is run groups all the way from working with folks who need 3 hours 3 times a week to help structure their lives, to address their issues, all the way through to folks who come in once a month and really just need to do a check-in. When we were asked to think about how we see the population and how it impacts what we're doing, one of the things that I think has been really important is for people to know how fast organizations have had to change how they behave to address this issue. If you went to Central Vermont Substance Abuse Services 10 years ago, we were dabbling in working with people with these kinds of issues with prescription drugs and heroin, and now that's the majority of the work that we do. And I think it was addressed before that it's a very different situation than for folks who become addicted to alcohol. Because with alcohol, your life deteriorates much slower. There's a little bit more discussion in families about it. You get more opportunities for others to see what's happening. There are people out there that we are serving that are coming through the door saying, I can't go to the clinic because my mom can't know. So it's been really important for organizations like ours to really adapt to that new world. So some of the things that we're doing right now and really putting our energy into is becoming more flexible, taking people as far as a phone call saying we're sending somebody over from the emergency room, digging up somebody who can see them that minute. If you tried to get an appointment with us years ago, you might have to wait 3 weeks. Now we're taking people as they come out of residential situations and seeing them the day they get released. So we've really had to adapt what we do. One of the reasons why I think they chose me to sit here is because another piece that we've done a lot of work around is connecting with public safety and what their role is. With the assistance of Ann and her team, we've worked with the police departments to look at how do we help support public safety, because they know these folks that haven't even made it through our doors. They haven't gone up to the hub to be evaluated yet, but yet they just got picked up again for breaking into a car to see what change they could get. And so we've been working on some creative things like a program called Project Safe Catch that has, that Chief Bombadier will probably speak about, and it came out of Montpelier Police as well, where they have rallied all of the law enforcement in the Washington County area to come to an agreement around police having the resources to be able to say to somebody, hey, you really need help. They see them in their weakest moment, and for them to be able to put a call in, and we'll get them in. We have had the police drive people up in their cruiser and drop them off and come pick them up when we were done to get them in. We have worked with police who have called and said, help us, this kid doesn't know how to tell their mom that they've been using opiates for the last 3 months and they don't know what to do about it. So it's been really important to be flexible and find programs like that. We're working with the WASARP group as well. The interesting thing is if you look at the previous panel, I think there was at least 6 of us in this group that have met at least once today, if not twice, to try to pull together the resources and look at what our pathways are like. And I think that that's really important for folks to know. The other thing that we're doing a lot of is education. I really appreciate the question from the parent who stepped up. The additional piece of advice I would give you is start talking to your kids now. I just met with 4 7th grade classes last week, which is really eye-opening. And I have to say, with the exception of very few, I was shocked at how little they actually knew. And I really think it comes from us, like Mary was saying, protecting our children and not wanting them to be exposed. We need them to be exposed. We need for them to know if they smoke a joint from a friend, they may know the friend, but they don't know where that joint came from and what it has in it. And so I really think it's important for us as a community to keep putting that out and to keep talking with folks and also talking with each other. It's easy to judge these people, but behind each one of these people that we see that come through our door, that their lives are a shamble, they have an entire network of loved ones that want to do something, and that includes you. And as long as we don't talk about that at the dinner table or at Thanksgiving or argue about what should happen and what the police should do, we're not going to get to a place where we can accept this for the actual epidemic that it is. The other thing is to call and use your resources. Not one person who is sitting on either of these panels is going to turn down a phone call to talk with a community member about educating them more. So I am representing Central Vermont Substance Abuse Services, but all of us can be a resource. Now, I know that Rory's going to talk a little bit about another whole project we work with. We work with, through the court system as well, on what used to be called a drug treatment court, but now it's a treatment court. This is a program that is specifically designed to work with what's considered high needs and high risk people. High needs of recidivism in the criminal justice system, and high needs in that the conventional walk through the door, get their medication, isn't working for them. They need a really comprehensive program. And we're working hand in hand with the judicial system to find ways to put some structures around them to actually engage in treatment. And that's how we kind of segue into public safety and criminal service here. Thank you.
Unfortunately, we're not going to start with Rory. Sorry. We're going to start with John.
Oh, I'm sorry.
It's all right. I want to take this moment to segue into law enforcement because a lot of the questions that were raised to me when these forums were put together was, please bring people in who can speak to where the drugs are coming from, how they're being traced, how they're being tracked, and what's being done in our communities to show that correlation between opioids and upticks in certain kinds of crime. So with that, I'm going to turn it over to John and have him talk about, from the state police point of view, what we're seeing right now.
Okay, my name's John Merrigan. I run the Special Investigations, and that includes the Vermont Drug Task Force and Narcotics Unit. I spent almost my whole career doing this either in undercover capacity or supervising undercover operations. And this is really the only thing I know with the state police, is drug work. From our particular point of view, it's all about distribution. How did this happen? How did it get as bad as it is today? When I joined the drug unit in '99, nobody that I had worked with had ever seen a bag of heroin. And I remember the first day that we bought it, I think it was in 2000, we all gathered around to look at it. Obviously, that's not the case anymore. Things changed quickly. By 2003, we were doing specifically heroin investigations and heroin, trying to infiltrate heroin groups. And by 2008, it was a full-blown off and running, and of course it is today. So what I'd like to do in a nutshell, if I can, for you is describe how opiates, heroin and fentanyl, which are basically sold as the same on the streets, your end user doesn't know if he's shooting a bag of heroin or a bag of fentanyl that's dosed properly, hopefully. So you can walk away with a sense of how does this happen. So like a lot of things, picture a pyramid. At the top, we've got the professional drug dealers, people that do this and bring in the large amounts. It's different than it used to be. The classic, when I first started doing this work, the classic pyramid model would be some type of gang coming from a different city that would set up shop, and they would bring, at the top would be the head, and there'd be a couple enforcers, and then there'd be a whole bunch of workers. And they came in with their own infrastructure and their own package. They'd hit a town, and they'd start, the workers would start making friends, and we would get introduced to them, and then start buying drugs up through the ranks, and then hang out with a little bit, and then arrest everybody. Really easy. I miss those days. That was easy, and then that group was gone. That is not how it works. One or two people will come in and bring an absurd amount of opioids with them. That's the top of this new pyramid that I'm trying to describe. The middle pyramid, which consists of the Vermont infrastructure. We are the ones that move heroin and opioids through the state. These are people that are moving opioids above their own addictive needs for money. They're making money. They're introducing their friends and girlfriends and boyfriends to these dealers. They're giving them places to stay. They're driving them anywhere they want to go. And for them, this is a good deal. They know this dealer. They have a measure of respect within their own social circle. There's some prestige if they're living with this dealer. And they, of course, the big thing is they don't have to worry about the heroin they need to not get sick. So they're going to get heroin at either a reduced or free, but they are absolutely contributing to the overall distribution of the product throughout Vermont. And then at the bottom is you've got your end users. These are the people that are addicts, trying to hold down a job at different levels in their addiction and different stages of their addiction. Those are the people that that haven't made it up into that infrastructure, that second tier. So the first tier is the ones, those are the people we're trying to put in jail. Those are the people we try to put cases on. And there's not a lot of us. Statewide, there's about 20 of us, and that's including me, and they don't let me do that kind of work anymore. So there's not a lot of people out doing that full-time in a proactive sense. And these are all undercover type officers that are proactively working cases, not like your uniformed troopers and officers that are responding in a reactive way to things that occur. These are people trying to prevent things from occurring. So the first tier is, of course, the ones we want to get, but the second tier is what's killing us and why we can't make any forward progress, because we are our own worst enemies. And I could say there's no family that is immune to having a loved one in this. Neither am I. Very difficult. I've been a lifelong drug cop. Happened. That's a snapshot of where we are in Vermont, and that snapshot has been the same, I would say, since about 2009 or so, 8 or 9, about. One of the things that we do have going for us on the good news side of things is that I don't think Vermont law enforcement, and this isn't a plug and this isn't fake because you're supposed to say this. This is actually true. We're working to Vermont, both Department of Health, Public Safety, police departments, state police, federal government. We're all working really well here in Vermont. It's a small state, so we all know each other by first name after a little while. If you're in this circle, you start to know each other. And we are doing something that's not happening anywhere else in the country. We're working together. We work with HSI, FBI, DEA, very closely on cases. They give us manpower, we give them manpower, and there's so many targets to go around that we don't fight about, oh no, that's my target, I've been working on him for 2 years. If you've got I know, but that's used to happen. If you've got a better case, we give it to you. That's the good news. The bad news is that there is, and this isn't a popular statement, but it's true, there's as much heroin now as there's ever been in the state. There's more now, opioids, heroin and fentanyl together. Fentanyl, we all suspect will be the new heroin. It's cheaper to produce, it's 50 times more powerful, and all of the economics that go along with that type of product. There's more now than there was 6 months ago, and there's reason to believe there'll be more in 6 months than there is now. So that second tier, which is the people that are really affecting the distribution, that's what we're really trying to work on. And for us, somebody that goes to treatment and comes out clean is a win. Jail is not a win for us. There isn't a cop that knows this game that thinks jail's a win for anybody. That is operating from an addictive point of view. And that's what I've got.
Yeah. And
Steve
there's
didn't
the sober.
thump on the desk on you.
No.
No, I did not. That was an important one to hear. And now we're going to get a little more local into what we see in our individual communities. So Tim.
Hi, I'm Tim Bombadier. I'm the Director of Public Safety for the City of Barre, and I have police, fire, EMS, and some other departments. But the ones that really concern the folks here tonight and the subject matter we're talking about are police, fire, and dispatch. And what we've seen. I've been doing this for 38 years now. John did a great overview of one whole middle section here that I don't have to cover. So Steve's not going to get the thump on the desk on me.
Doubtful.
Doubtful? We'll try it. I originally started looking at this as crime stats, and crime stats are kind of flat. There's a little bit of a deviation here and there in things like thefts, robberies, and assaults. And it's not really until you start getting down into the meat of a case and reading a narrative do you really make a connection. I don't think anybody can just run crime stats and point and go, Oh, this is obviously connected to opioids, because you have to read down into the cases. Really, what types of crime? Probably robbery is the one thing that we have seen a little uptick in. And all of the robberies, when you start talking to the people when we catch them, it's connected to heroin, plain and simple. We haven't had anybody robbing a bank for any other reason or robbing a store for any other reason other than to buy heroin in the last 4 to 5 years. So those are one I feel comfortable saying these are connected to heroin. But back in the day, you had drugs, we arrested you, you went to jail, unless it was marijuana. But if you had cocaine, which was the drug of choice, which John didn't mention, but that was a lot easier. You got arrested, you went to court, you maybe went to jail, you maybe got probation, but the cases were easy. And there were people in Vermont that could say, drugs don't affect my life. Drugs in Vermont have no effect. I really don't care about them. Anybody that says that today is fooling themselves. Heroin affects everybody in here, whether it's a neighbor, a family member, a friend. You end up being the victim of a crime, of an assault or a theft or a robbery or some other connection to your life. Something as simple as an increase in the price of things you buy because the store you go to has had so many retail thefts. Everybody in here is affected. And I think when you look around at the panel that's here tonight, you get a good idea of what it's going to take to put a dent in this. It's going to take a team approach. We're not going to arrest our way out of the heroin problem. We're not going to treat our way out of the heroin problem. No one group of individuals that have been up here are going to solve this problem. And when I say group of individuals, I'm talking about the other people in the room. This is a community problem, and I see some faces I know, and folks come to me and like, Chief, why don't we arrest them? Well, we need information. So if you have information and you see something, please tell somebody. If you live in Barre, even if you don't live in Barre City and you want to call me, I'll make sure it gets to the right people. Call me. Little tidbits of information piled up, as John will tell you, help the undercover guys immensely. But when we look at what's going on in Barre City and what we have for issues, first responders, we see people at the worst point of their day. They're either getting arrested and they're dealing with the police, or they've overdosed and they're dealing with the paramedics, or they're on the phone and they're all cranked up and they're trying to get something through to dispatch, but they're not making any sense. And first responders see people at the worst, and they are, for a lot of people, the first point of contact for the system. And that's why we have partnered with Washington County Mental Health, the emergency room, Deb, Rory's office, the courts. That's why all these systems in place, because no one thing's going to stop it. In Barre City, we are part of Project Safe Catch. We have a police social worker. So if you come to the door and it's not necessarily a police problem, I have a person that can come help you. If you know somebody that needs help, send them our way. You might not think it's our job, but it is part of our job. That's what we're there to do. Where do we go from, ooh, wow, that was loud. Where do we go from here? I think we're building the relationships in Central Vermont that we need to build with our service providers. The silos that existed a decade ago between the service providers in the community are being torn down on a daily basis here. There are 60+ service providers in the community. We are working at making sure that people not only get the treatment, the ones that need treatment, the ones that need to be arrested and go through Rory's shop, they get arrested and go through Rory's shop, but there's other wraparound services that are components to having a healthy life, like a roof over your head, food, money, all the things a lot of us take for granted. And this team approach is going to be the thing. Probably before Steve starts thumping on the podium at me, I just want to touch on one thing, well, two things. How it affects the elderly. There was a question earlier about how it affects the elderly. Where we see the elderly affected in law enforcement and on the EMS side is through victimization. Whether grandma comes in and her diamond rings that didn't fit her anymore because she has arthritis and they've been in the teapot on top of the fridge for a decade are gone, or whether pills are missing out of a medicine cabinet, or whether it's great-grandpa's checkbook now has a negative balance in it. Those are where we're seeing it affect our older citizens. The other question when it first came out, so I'm going to address it, was Narcan. And it was, why are the cops giving people Narcan? Twofold, plain and simple. Number one, it saves lives. And it's easy to say that, but I'll give you a little story. We had a young lady, this is when Narcan first came out. Pristine young lady, out partying with friends, never drank, never done drugs. The first drug she tries is heroin. Or she was told it was heroin. It might have been heroin and fentanyl. If it had not been for Narcan, that would have been her first and last time trying drugs. So why do we carry Narcan for law enforcement? Why don't we just leave it up to EMS? That's the number one reason. The second is officer safety, whether it's EMS safety or police safety. We have had officers in Central Vermont get accidental exposures to heroin and fentanyl, and they've had to go to the emergency room. So it's twofold. It's not, as somebody put it to me, well, that's kind of mamby-pamby, isn't it, Bomber? It's not. There's a need for it, and there's a reason all EMS and law enforcement carry it. There's other questions, but I'm way past 7 minutes, sorry.
Captain Martell.
So I can assure you, Steve, you probably won't have to pound on it for me. But good evening. I'm Neil Martell. I'm a captain of the Montpelier Police Department. Been in law enforcement in Montpelier almost 31 years. Like Chief Bombadier said, when I first was asked to sit on this, I said, well, I'll look at stats, and stats will tell me. And what I found was very similar. Over the last 4 years in Montpelier, our criminal trends are pretty consistent. They ebb and flow. In the last 4 years, some 50 to 100 incidents per year. So we're not seeing a tremendous spike in criminal activity. And that is reported crimes that people are actually experiencing or are victims of. So, but there's no denying that we have a heroin problem, that we have an opioid problem in this community. We have it in the schools, we have it in our communities, we have it in our neighborhoods. Most of you here today are here because you know, or because you know of someone, or you have concerns about it. And they're genuine. And from law enforcement standpoint, as John and Tim echoed, 30 years ago, heroin was a non-existent thing. Didn't exist. You saw, the first thing you saw was marijuana, then you saw cocaine, some crack, and then this thing called heroin showed up. And it's changed the way how law enforcement does its daily business in a lot of ways. And it's tough to put your finger on exactly what that is, but you've heard some stories tonight about how law enforcement are doing things that, certainly when I signed up to be a law enforcement officer 30 years ago, I didn't think I would be taking care of some kids while their mom was OD'd and on the way to the hospital. That wasn't something, I signed up to be a cop to catch the bad guys, right? That's what you did. What I've realized is it's become much more complex than that. And it probably always was more complex than that. But we have to be a lot of things to a lot of people now. And that's just kind of what society asks of it. But it is trying. It's trying for law enforcement officers to do all these things. And heroin has caused some of these things to manifest themselves. Families that are disruptive. We see it in our schools where there's increasing rates of truancies because parents aren't doing good parental jobs because they're battling with addiction. We see it, in some criminal activity, your petty crimes. I said they haven't spiked, but they're consistent. Our property crimes, are those larcenies, those burglaries and stuff like that. Those people, as mentioned, are doing those crimes to get money to usually feed an addiction. So what are we doing? Well, as mentioned again, we started, Chief Tony Fakos about 2 years ago, started down a path based on the Gloucester PD model of what they were doing, which was getting people that were facing addiction. You know, if they came to the police department, we would get them help because their intervention is key. And so based on that Gloucester PD model, we started a process with Washington County called Project Safe Catch, with Deb Hopkins and her group at the abuse treatment program to get intervention to anyone that came into us. We would get them to treatment if they were battling an addiction. And I think, you know, that's an ongoing process. I think it's something we take value in. To be honest with you, I'd like to see more people participating in it. You know, we didn't know what to expect. We know we have an opioid and addiction problem in our communities. To be quite honest with you, I think it's underachieved, but I'd like to see more, you know, and that might be a shortcoming of us as law enforcement, perhaps. But, you know, we need to do a better job maybe getting word out there that we can offer these services to people. As Chief Bombadier mentioned, Narcan. About a year and a half or two ago, we made a decision at our agency to have all officers would carry Narcan because it's the right thing to do. It could be your son, daughter, brother, or sister that we use it on and save a life. With that thought process, you know, it is the right thing to do. And it does work. We've seen success with that locally to use it to help save lives. Other things that we've done, Montpelier, as many other PDs now, we've put up a drop disposal box. We partnered with CVS to bring that in. We have one at our station. We're tracking that, and we're taking anywhere from 25 to as much as 40 pounds a month of unwanted prescription drugs, and we're turning them into the Department of Health. So we're getting those kind of unwanted prescription drugs that were out there before. We're making a measurable impact on taking those unwanted drugs and getting them disposed of properly. Also recently, as the City of Montpelier, we put up some sharps disposal containers throughout various locations in the city, including we have one at the police department, we have one at City Hall, fire department will accept them. I think we put one in the senior center and the rec department. So we have those kind of sharps disposal, needle disposal sites where people can drop off, unwanted needles so they're not being found in our playgrounds, on the side of our streets, stuff like that. We're also working with the State's Attorney's Office with treatment court. We understand, as Chief mentioned, we're not going to arrest our way out of this. It's much more complicated. It's much more evolved than that. Simply going out and arresting people that are addicted to drugs or opiates or heroin or whatever is not going to change that. People without treatment are going to continue to be using drugs. The key part of that, obviously, is an educational component. We have to make inroads and continue to make inroads, I think, in our educational system to teach young people about the hazards and how to make the right choices. So what I'll say is, in Montpelier, we kind of have this perception that it's a good little town, it's the smallest capital, things are great. Things are great. We're very fortunate to have all the wonderful things we have, but it's not without some problems. The opioids are here, they're in our community, they're in all of our surrounding communities. There's no magical line in the sand that separates Barre City from Berlin, or St. Johnsbury from, Montpelier, or Burlington from Montpelier. Those drugs will travel. The people that are doing drugs or selling drugs in those communities will also come to these communities as well. So we have to be vigilant. We have to utilize all the resources that are here tonight to be good partners. As a community, we have to be resilient to make an effort to make this a priority as we go forward. Thank you.
Rory, before we get to you, I'm going to make you wait again. For you two, a lot of people talk about the public perception of what's going on, and I'm assuming that a lot of what you're seeing is the second tier that John was talking about in our communities of the kind of in people living within the community and acting out in that kind of serving as that army. But how do you, when someone from the community comes up to you and says, well, why aren't you arresting that guy? You know that's a drug house. How does that happen? And how does, you know, why can't we stop it? You kind of addressed it, but you're not talking specifically about kind of the stigma that comes with that. And it's hurting our communities, and that's the one thing that we all seem to hear kind of across the board is, well, there are drugs here, why can't something be done about it?
And agree with you 100%, Steve. People come to us and say, there's drugs here, why aren't we arresting them? I think John gave a good overview of what goes on with the undercover operations in Vermont and how they run, and it goes back to my statement of if you see something, say something. We've been very fortunate in Barre City, and people have been very patient with me because I've been the point of contact. But when I say me, I mean patient with law enforcement with regards to how cases go and how cases get disposed of and the timing on those. I have asked people to do nothing more than give me license plate numbers. If this is the car across the street, send me a list of license plate numbers, or if you know who the people are by name, send me them by name. We will get them to the right people, because the majority of the time, somebody in an undercover operation is connected to these folks. And it does take time. These are not overnight cases. Just in the last month, you may have seen every week or so, 2 Vermonters charged in Springfield, Mass. 2 Vermonters arrested and brought to Springfield, Mass. It takes time to build these cases, but some of the people that 3 weeks ago now, I may have my dates wrong, 2 or 3 weeks ago now that were arrested in Barre are looking at 30 to life sentences for distribution of heroin. And some of those people aren't the top tier. They're the middle tier. They're the people that when it was cocaine, they were like catch and release because they were used to get to that next tier. Is that a good way of putting it? Yeah. But if you see something, say something. Being quiet or just complaining about it on the sidelines, I'd rather have you complain to me because I hope I can get you convinced to be helpful to us. It's really funny because sometimes the plates end up coming back to undercover officers. That's a whole other stuff. But the information...
But I guess my point is that giving the reports to you doesn't end up... You don't see outcomes of that immediately, and that's what's frustrating to the community.
But and here's the promise I have given people when they have been patient with me and said, I'll put up with you. We set timelines to get back to each other. I might get to a point where I make a phone call to the captain and say, hey, it's either we have to do something or we're going to do a no drugs here week, which means police car, kind of like what Chief DePozo was talking about, cops on every corner, marked police car in front of the house that's a problem house. That has probably prompted John some hair loss because he's, we go way back, because he's sped up investigations and made arrests just to keep me from doing that. But, you know, those are some of the options available to us, and I'm not beyond doing that. And for the citizens that have been very patient with me, if you're here or you're going to see this, it's really appreciated because it does take care of those top echelon people and the distribution Vermonters, which are, from my perspective, as big a problem because anybody with $10,000 worth of heroin, no matter where you are up here, can come in Vermont and in 3 days get themselves ingrained in the Vermont distribution network and move stuff through your community. And it doesn't matter whether it's Barre, Montpelier, St. Albans, Springfield, Rutland. This is the same in every community in Vermont. So it goes back to, if you see something, say something. If I ask or your chief asks you to be patient, have the hard conversation. Okay, when's the drop dead date here? And I've extended the drop dead date on a couple of people, and it's turned out very well. But it is frustrating. It's frustrating from our end, from my end as the chief when I'm talking to undercover guys, whether they're ATF agents or they're state police guys, which are where I came from. It's very frustrating because as the chief, I really don't want you calling me complaining if we know what's going on, but I also have a duty to listen to you and enlist you as someone that can help us.
Neil, anything to add?
I will just add that oftentimes when you say, or somebody comes to us and they say that we know this is a drug house, we know it's a drug house too, and we have some ongoing, usually, almost always we know about it, but we still take that information. And as they indicated, these investigations into narcotics take time. They have to, there's a process that needs to happen to work these cases, and it's not instantaneous. I know that's frustrating. Like we say, it's frustrating for all of us, but it is kind of the way the process has to play out. But the information is of value. People should come forward and give us information. Oftentimes, though, we're already aware.
Right. All right. Well, talking about the process continuing, our state's attorney, Roy Tebow.
So good evening, I'm Roy Tebow. I'm new appointed within the last month as the state's attorney for Washington County. And just to finish up the chief's comment, typically when those people get really upset, the answer just becomes, it's at review with the state's attorney. So, that said, this evening I want to take the opportunity to talk about the judicial role and judicial response to the opiate epidemic here in Central Vermont. I can say as a fairly seasoned prosecutor, there's no challenge that is greater or more complicated than this. And oftentimes when I think about how the court, including prosecutors, defense counsel, and the judges themselves can respond to this, I feel like we're sort of sitting at a dinner table with a bowl of soup, trying to share a fork and a knife to have the meal. Or the second course comes out of a wonderful steak and we're there with a spoon. The problem with a judicial response is we are not seeing a vast majority of people who are currently using or are addicts. We're catching and seeing people when they have hit a rock bottom or are on their way there, when they've broken the threshold and actually gone to the point of committing a crime. And these crimes cut across every category: assaults, domestic assaults, sex assaults, human trafficking, robbery, armed robbery, burglary, home invasions. All of these things are done out of desperation and in a cloud of what addiction and the impairment that accompanies it does. These actions tear apart family units, and they put people in positions where they're exploiting sometimes the only people left who will help them. So when we hear, and I heard a question about, is there an elder abuse element to this? Absolutely. And right now, there are two people who are bearing a disproportionate burden in the opiate epidemic in Central Vermont: our children and the grandparents, who oftentimes are having to step in to provide that role. I spoke with our juvenile prosecutor, Kristen Ghazi, earlier today to get some statistics and looking at our CHINS docket. For those of you who don't know, CHINS is Children in Need of Supervision. So this is when DCF or the state has had to intervene and either take direct custody of a child or is directly involved in the management of that child. In 2016, 52% of those cases in Washington County entailed substance abuse as an issue. In 2017, it was 59% of those cases. And most of those cases are involving either direct abuse or neglect. And of this past year, in terms of neglect, 20% of those cases involved households that were so unsanitary the children had to be removed immediately. So there is a crisis here, and this crisis propagates itself. When I look at our, if you look at it this way, a profile of defendants we have, they're usually one of three things that they have, or sometimes a combination thereof: a history of trauma, a history of poverty, or a history of behavioral and mental health issues. Oftentimes those things run together, and oftentimes they are multi-generational. And it's sometimes frightening where on the same docket or the same arraignment day, we will have sometimes 2 or even 3 generations of the same family in court for different reasons. That really demonstrates the strain and the multiple dimensions of this problem. We can't incarcerate our way out of it. We can't arrest our way out of it. We need to take action in areas of prevention and education. So when we talk about things of state budgeting time and town meeting time, when we think about things like an education budget or school budget or what the state's going to do and where its spending priorities are, when it comes to the opiate epidemic, I think in this audience, most people would probably agree we want to have more teachers and more opportunities for kids to avoid a life that has an addiction as a component versus paying for more probation officers on the back end. It's a very complicated situation. As prosecutors today, I think we face a number of challenges that probably have always been faced, but they're much more pronounced now. And I'd pose to you this question, and think about it for a moment. Let's say you have an armed robbery. Someone goes into a gas station, holds up a knife, demands money from the clerk. Clerk refuses. They cut the clerk, and then get the money and run away. That person happens to have a drug addiction problem. Let's say down the street or in another town, the same exact thing happens. Gentleman goes in, threatens a clerk, waves a knife around, hurts the clerk, and then gets away with money. Should we treat those two people differently? That's a really tough question. Should we have more empathy for someone who approaches the judicial system as an addict versus someone who just is a criminal or wants money? I'd say that all this is rhetorical. There's really no right answer to it. But as prosecutors, we are oftentimes in the position with our defense counsel counterparts and the court of trying to sort through what put that person there. How do we best tailor an outcome that is, one, provides accountability to the community, two, does something to address the harm that their actions have caused, and then three, in the long term, reduces risk. We heard the term before, catch and release. Well, if you're catching and releasing, that's maybe not the best way to describe it or the best opportunity. I think in our office, we've adopted the view that when someone does have the unfortunate run-in of hitting rock bottom with an interface with the criminal justice system, that's an opportunity. That's our first and perhaps the last opportunity before an overdose or before things get even worse to intervene, to get them to services, and to ensure that there is some meaningful response. And that response can come in many different forms. There are diversion programs that now focus on, many of you may have heard of the Tamarack program. That is a traditional diversion program with a contract to also avail, for that person to avail him or herself of treatment, whether it be behavioral health or mental health treatment or substance abuse treatment. As we work our way back to the traditional court system, there are a number of things, and a good segue to talk about adult treatment court in Washington County. In the last year, 35 people in Washington County were served by adult treatment court. It is a wraparound program that involves case management, both for substance abuse and for mental health. It has participation from members of the prosecution, from the defense, and it's overseen by one of our two presiding Superior Court judges here in Washington County. I wish I could say that every case that comes into treatment court is successful. That's unfortunately not the case. But these high-needs, high-risk cases are addressed in the most meaningful and I think powerful way we possibly can, which is looking at people with sometimes hopeless amounts of felony criminal exposure for burglaries and other things that would result in years of time in jail, and giving them a second chance in many respects, or perhaps the first most important chance to rehabilitate and at least get their addiction under control. I've heard from many people in the community in my previous time as the chief deputy here in Washington County, now a little bit as the actual state's attorney. There are people who doubt treatment court and its effectiveness. There are people who question or think that it's some sort of way to let people get out of jail for free, to fake it, to go through treatment, go through motions. It couldn't be any further from the truth. It's an intensive program, and I think that I'd hope that people in the community recognize that a struggle with addiction and addressing it in that intensive manner is far, far harder than just going to a jail cell, sitting there and riding out 6 or 9 months. It takes dedication, it takes time, and many times that road is fraught with setbacks. Relapses are a reality of addiction medicine and treatment. And we try to respond to those in the best way we can from the judicial system and from our prosecutorial office. And when we look at how a judicial system can respond, I think the cornerstone of it is empathy. It's not just empathy for an offender or for a defendant who comes through. It's empathy for the victims who are affected by this. It's empathy for the parents who are sitting there watching their son or daughter go through this. It's empathy for the child sitting up in juvenile court, sometimes moving from foster home to foster home while their parents are struggling to get their own lives back together. Prosecution without empathy is certain to fail. And I think in a place like Washington County, it's important to note addiction and crime doesn't discriminate. There are addicts in Montpelier, there are addicts in Calais, in Waitsfield, in Fayston, in Barre City, in Northfield. There are victims in each of those towns, and there are people affected by it everywhere. Final note I'll say on this, and I'm happy to see we have a victim advocate from my office here today and also one of our deputies. I think that being involved in the community is important, and one of the things we strive to do in our office is be responsive and work hand in hand with law enforcement, with our partners in treatment, with those who are engaged in the community and trying to make a difference. Because at the end of the day, every person who sits at the defendant's table, one way or another, is likely going to come back and be a part of our community. They're going to be part of our community as our neighbors, and from our office's standpoint, many of them unfortunately come back as either victims or witnesses in our office. It's imperative that we treat people in the judicial system who are struggling with addiction with dignity and respect and try to work towards outcomes that enable their success, reduce their risk, and help them in their battle against addiction.
Thank you. Let's take a few questions for this panel.
Hi, thanks for being out here. My name is Elaine Wang. So that 80% figure of people that are not seeking treatment was very striking. So, and we've heard about risk factors. So I was wondering about ready factors. What makes people ready to pursue treatment? Can we all be enlisted in helping recognize when someone is in that place? Hopefully it's not when they're at rock bottom. Maybe we're all spotting that every day.
Go ahead, anybody.
The first point is to talk about it. Statistically, a person makes 7 attempts. The average is 7 attempts into recovery for anything: cigarette smoking, heroin, alcohol. But you have to be willing to have that conversation as a community and pull it out from it being stigmatized as much as it is. That's key.
I think it's really it's a big challenge. You know, when do you know you're ready for treatment? I mean, you know, we heard some of these examples here of, you know, they got involved in the criminal justice system, or their child, DCF, got involved, and that was the leverage point to kind of make them want to make some changes. It's different for everybody. I mean, I don't know what the bottom line is for one person to the next. You know, some people, you know, may get to the point where, you know, they overdose and they go right back out there, and they shoot up again. And I don't think there's a quick and easy answer for it. But you know, as I was saying earlier, you know, that issue, the importance of compassion for these people who are struggling with this disease is so critical. You know, if we can't be compassionate to them and their struggles, you know, there's not much hope that for them to feel like when they're ready for it, that there are going to be people there who want to help them.
Anyone else have any questions? Yes.
Hi, good evening. I work in an educational setting. I'm a mandated reporter. At the present time, I work in a specialized setting, and our adolescent and young adult population come from a background of trauma. It's not uncommon for our students to return to a setting in which the trauma occurred, and it's not unusual for that to be drug-related. So as a mandated reporter, when we hear of an incident in a home, we first call DCF, and almost always it doesn't fall within their framework of responding. What would you suggest, who would you suggest our next phone call be to? Our students are not necessarily connected with a mental health agency, and they don't necessarily have a support system around them, and the adults in their world may be the most secretive people with whom we would interface. So who's out there to support us?
That really depends on who's going to make a connection with that individual. I mean, in our school system, we have school resource officers, as does Montpelier.
So this is not a public school setting, and we don't
public school setting. Our school resource officers go to private schools too. So they're available for private schools. If you're in Barre City, the school resource officer goes to St. Monica's, for example, and does programs there. So there may be a connection there. It may be something as simple as reaching out in Barre City for myself or the police social worker, which is Brooke Pouliot. Brooke is really, probably should change her name to Resource Navigator. She's a wealth of knowledge and really a compassionate individual. We're very fortunate she's worked with children for 10 years prior to coming to Barre City. So she can direct people to proper services and where that intervention might take place to get somebody some help. She may not be the person giving the help, but she may know where to go. More likely than not, where to go.
Thank you, that's very helpful. So we draw from an area that extends from Milton Colchester to St. Johnsbury to Northfield, so we cover a lot of supervisory unions. Is there a particular agency that can serve us?
I think that a number of schools will create a relationship with an organization, a treatment organization that will help assist them. I don't have a lot of information about what you're drawing from, but I think some of the things Ann talked about were really important too. I think oftentimes what we do is we see an issue and we say, who do I call to address this issue? Those kids are going to have that issue throughout their life. And so not only looking for who can come in and help, but how do you actually help those kids? What do they know? What don't they know? Narcan is an interesting adventure when you're talking about young adults in the home, knowing what it is if they have parents that are users. That's pretty scary stuff, but that's part of what we're doing in the state. There's 2 locations here in Washington County where anybody can walk in and get them treatment associates and Central Vermont Substance Abuse Services. And to be able to really try to help empower those kids to identify those 3 people in their life who they can go to too. That isn't just the school, because it is different to talk to a mandated reporter rather than the neighbor that you actually trust, and to try to help pull some of that together. So I would encourage you to try to create a relationship with an organization that can be a resource, but I also think really, you know, you're handed some kids with some real traumatic background. They need to feel some power in being able to take care of their own lives, and it's hard work, but it's going to help them in the long run, my suggestion.
Yes.
Lucas Herring, City of Barre. 2-part question. The first one is more about advice that we can give to the public, because I talked to someone yesterday about filing a complaint just related on trash ordinances, and now you're talking about something dealing with either sale or drug addiction issues. So the first part is, how do we get the public to actually report that information when they have a fear of either retribution or their name being attached with these complaints that are coming in? And then after we get them to do that, the follow-up is, if there's 80% of the population out there that isn't being served that could be, do we have the resources in place if there was an influx of these individuals that needed those resources? Thank you.
Want to handle fear of retribution?
It's an interesting phenomenon that we deal with, and people are reluctant to come forward. I think it goes back to you. From a police perspective, you have to build relationships within your community, and you have to engage those people on other occasions where they know that you as the police are there to help that community. I think a lot of times people only go to the cops when something bad has happened, and that's something that has just kind of been an evolutionary thing. But all communities need to kind of break down those things so that people view police as more than just the bad response to something bad. So, building relationships within all of our communities is something that, from law enforcement, we need to continue to grow, continue to work on, to have engagement with our communities in a reactionary approach. The fear of retribution is really a perception thing that is kind of unfounded, I think. I mean, more times than not, that fear is just something that they think is going to happen that in reality doesn't. So I mean, we can try to put their mind at ease at that, but I think you have to think about that relationship issue. If somebody is uncomfortable because of that, then they don't really know what the police can do for them. So in some ways, if we can strengthen those relationships before they need us, they'll feel much more comfortable coming to the police, knowing that we're there to help them.
What I would say for anybody that's in a situation where they are pretty sure they know what's going on in a place or they have specific information, but there is a real or perceived fear of retribution, and sometimes it can be legitimate. There's multiple different ways. There's multiple ways to give different types of information to the police. So you can come in and talk to us, and everybody knows you just came and talked to the cops, and the next thing you know, the neighbor's getting busted. That doesn't look good for you. That doesn't work very well. So depending on the situation, it's very possible to give a completely anonymous, confidential information and ship it off, and you guys do what you do with this. You can meet with guys that work for me, guys that work for these guys, in a confidential basis and give more detailed information, and unless you consent, then your name isn't going to go out. So I'm trying to answer this question specifically. That's possible for that to happen too. Lots of times the police, if we don't have any information other than what you're giving us, we can't act on it. The rules of engagement here in Vermont are fairly strict and fairly tight. So you may have to do something overt to help the investigation. That doesn't mean you have to. It may be something that a lot of people want to do it, a lot of people don't want to do it. So there's a lot of different tiers of way to do it. The big thing is call somebody that knows what they're talking about, somebody that you trust, and give them the information.
And if you just want to get the information off your chest and make sure it gets to the right people, you can use the Vermont tip line. It's for all crimes, not just drug crimes, but the Vermont tip line, it's online. You can be anonymous. It goes to the Vermont Intel Center. They distribute it to the proper authorities in the area of concern. That's probably the best mechanism if you want to stay anonymous. As far as retribution goes, I've been doing this close to, 38 years and working on more. The number of times, threats, yes. Actual retribution, I'm glad to say I can count them on my hands in 38 plus years. So the retribution is a perceived fear, and for the folks that have that fear, it's a genuine fear, and we understand that concern. We'll do our best to talk to people about making that fear go away. But if it's a genuine fear, the Vermont tip line, anybody that's got internet access on your phone or on a computer or on a tablet, you can send one in through the Vermont tip line.
Great.
I think the other part of your question is around the issue of capacity within the treatment community. I think, you've probably heard in the news and the media that, there are challenges around the issue of capacity, particularly in residential. Very often, if somebody is appropriate for residential care, there may be a wait to get into that residential care, and so what do you say to somebody who's actively using but wanting to get into residential? That's a tough choice for those folks. And I think in our community here, there is access to services. If we got an influx of 4,000 people, no, obviously, but you know, the reality is that we're not going to be seeing that many people coming forward that quickly. I mentioned that, you know, we're seeing probably about, you know, 8 to 12 people coming forward a month at this point in time. You know, if we could double that, that would be fantastic. You know, those numbers of seeing the number of people who've come into the hub is great. You know, I'd like to be able to see us increase the capacity of our prescribers who are working in primary care, and you know, that's one of my primary goals and responsibilities is to see about expanding that level of doctors. We are faced in our community with a handful of these prescribers are facing retirement, and you know, within the next 3 to 5 years, you know, we'll need to be bringing on more prescribers. And at this point in time, you know, we've got a few folks who've expressed interest, but there are communities like down in the Mad River Valley where we don't have any prescribers, and you know, that's a challenge for us.
We're going to take one more question and then we're going to wrap up.
Hi, I'm Hunter. I'll try to articulate this as best I can. I'm familiar with Matt and with the recovery options in the Central Vermont area, but I was wondering what initiatives, given that the population that these people are largely working with have a negative connotation with law enforcement as well as DCF and other state agencies, what potential initiatives are underway to address the need for case management services after the initial getting clean and moving on so people can file for unemployment, get on Health Connect, get on Medicaid, and do the other things that are needed to live a productive life.
Maybe may fall to one of our other panelists too.
It's a little bit everybody. So there are partnerships that are being developed as we sit here tonight.
If you move the mic closer, Tim.
Oh, sorry. I'm not used to having, usually if the room's small enough, you can hear me.
Yeah.
There are partnerships being developed as we sit here, directed just towards the areas of your concern of what happens after. They're in a little broader manner, but they will capture people with opioid addictions also. And they're really directed at a central location for resource navigation to make sure that if you walk through the door, there's a smiley, friendly face of the community that's there to help you. They may not be the actual individual to help you. They may direct you to the Turning Point. They may direct you to Washington County Mental Health. They may direct you to Central Vermont Substance Abuse. They may direct you to one of the housing agencies. They may direct you to the food shelf or a thing that combines all of these, which is life skills classes. I mean, things a lot of folks take for granted. Going shopping on a budget, a lot of us take for granted. Knowing how to cook dinner, a lot of us take for granted. So this is all coming together. I think within the next 60 to, no, I'm gonna go back because I wanted it at 30. I'm gonna say 30 days, maybe 45. You're gonna see some new things around that area with the whole concept of resource navigators and a really stronger team effort towards these. We've shown it's worked in the past when we've done it short-term for recovery after the floods, and we're looking at doing something like that long-term moving on. Did I get through that without giving up any secrets?
All right. Thank you, all of our panelists. So as expected, this has been an informative and critical look at the opioid crisis here, and I think we should all actually be proud of the fact that this evening we came out together to discuss this important issue, and I want to express my sincere gratitude to all the panelists who agreed to come out and offer their insights tonight. It's been very educational. I knew it would be, and I'm sure we can all agree on that. Hopefully this information is something that allows you to have a better understanding of what's going on in our community right now, and I would urge you to please share what you've learned here This will be taped and rebroadcast on Orca Media and potentially on other public access stations around the state. And I'm sure Orca Media would be happy to make copies available to you as well. And on behalf of the Times-Argus, I want to thank you for all of your support tonight and for your ongoing support of the work that we do each day in your community. And I hope you all have a safe drive home, and I thank you again for coming out.
Steve, can you give a shameless plug?
Oh, hold on.
Can you give a shameless plug?
Yes.
If anybody would like to be part of a project like I discussed at the end?
Pull up the mic.
Sure, one shameless plug. If anybody out there would like to be part of what we discussed with regards to a team effort in a central location, shameless plug, you can reach out for either Mary Moulton, wave Mary, Mary's been all in from day one, or Deborah. Deborah's been all in from day one, or Bob. Where's Bob? Bob, raise your hand, Bob. Bob, raise your hand. Or Bob, he's been all in for day one. And finally myself, and we will put you on the list, and we really would appreciate any and all help we can get. Thank you.
Good night, everybody.